Grazie Anel.
If you're healthy, you do not need to manage your fluids because it goes pretty much automatically. You just drink a sip of water if you're thirsty. But this is much more difficult if you're critically ill, and we have to do it for our patients. And we can actually use ECHO to do that. We have a real expert who knows how to do it. You already know Bruno, and I would like to ask Bruno to show us how we can manage fluids in critically ill patients. Bruno, please.
Thank you, Thomas. We know that there are some clinical signs that can advise us that there are some problem in fluid status of our patients. Heart frequency, blood pressure, central venous pressure, or a bleeding are very, very important issue in our intensive care unit and operating room patients. But echocardiography, and especially TE, plays a very important role in our OR and ICU patients.
You know, Bruno, when I listen to anesthesiologists talk about fluid management, I always start to panic because physiology for me is so complex. Can you make it simple for us so that we all understand what the main principles are?
Yes, Thomas, you are completely right. The physiology in these post-surgical patients it's extremely complicated. But I would like to emphasize two very important physiological principles. One is the Frank-Starling curve, and the second is the respiratory ventilation variation. In the Frank-Starling curve, we can appreciate three different volemic situations. We have in the first part, in the ascending curve, the hypovolemia, then we can see the normovolemia, and the last one, the red one, is the hypovolemia.
But Bruno, what happens if you give volume in these different states?
We have different answers from our patients. In the hypovolemic state, if we give a lot of fluids, we will have a big incremental of cardiac output. That is what we need and what we want to reach. In the second part of the curve, in the normovolemic situation, we could give some fluids, but take care not too much, because it's very easy that we go into the hypovolemic situation, and here would be very bad when you give some fluids. The cardiac output will not increase, probably will decrease.
I mean, in addition, imagine if you have someone who has in heart failure, who has too much fluids in the body, and you even give him fluids in this situation, I mean, you'll probably increase his heart failure. So you have to know exactly in which part of this curve you are when you apply fluids. Is that correct?
Yeah, it's extremely correct. The second physiological principle that I want you to remember is the respiratory and ventilation variation. We have to keep in mind that during spontaneously respiration and mechanically ventilation, there are some different variation in our heart chamber and vessel. But the most important thing that you have to keep in mind is that the right atrial pressure will increase during inspiration in mechanically ventilated patients, and the reversal effect will happen during spontaneous breathing.
Now, Bruno, you're talking about right atrial pressure, but how can we see these variations on an echocardiogram?
Thomas, you know we can see the variation on the inferior vena cava.
Okay, but from a transthoracic approach, I know how to see the inferior vena cava, use the subcostal approach, but can we see the inferior vena cava also in a TE?
Of course, Thomas. This is the view that we want to reach, the low esophageal hepatic vein view, and let's look the video how to get there. We start looking for the four-chamber view, and then we modify our view, turning the probe to the right side. We have to change the degrees to 20, 30. I find normally with 40 degrees. And then we insert the probe inside, and then we will look for the lever that is on the right side.
Okay, so this is the inferior vena cava we see right there. Just a question. We lose the image on the way towards the inferior vena cava. Is that something that happens all the time, or why is that so?
It's it happens almost every time that you lose your image, but if you continue inserting the probe and turning to the right side, I'm sure 99% you will find it.
Yeah. So you say that we can get this view in practically all patients?
We can get this view in the most of the patients. I think it is not a difficult view. But how can we see this variation? Naturally, we can see it on the 2D images, but I prefer, and I will be more precise, with an M mode.
You mean you're using the old-fashioned M mode?
Yeah, why not, Thomas? Old-fashioned is not always so bad.
And it does have a number of advantages because you can probably see the fluctuations much better. You have a very good time resolution, but there's one important thing that you need to know when you adjust the M mode.
Exactly, Thomas. You have always to reduce your horizontal sweep so that you will have in your screen not only 3, 4, 5 bits, but you will have 20, 30, or 40.
That way you can see the variations of the intravenous cave and you could be able to measure them. But what do we see on this image now?
When I look to this image, I see two different respiration situations. In the biggest diameter, I see the inspiration. In the smaller diameter, I see the expiration.
But is this always this way?
No, this is only for mechanically ventilated patients. It will be in spontaneous breathing patient, the reverse.
Okay, so keep in mind, this is what Bruno just said before. It depends on the situation, if he is mechanically ventilated or spontaneously breathing. So the variations are reversed in this situation.
Now we have to figure out what and how to measure. The first thing that we look for is the distensibility. The distensibility is the property of the vessels to extend themselves. And there is a wonderful formula that we can use, and this is the distensibility index. And it works something like this: the difference between inspiratory diameter minus expiratory diameter divided by expiratory diameter.
Times 100, right? So it's a percent value.
Exactly, Thomas. This is the percentage of distension of the vessel.
And how does this value help us now?
An incremental between 12 and 18% or above it means fluid responsiveness.
That means if you have a value above 12 to 18%, you should give them fluids and they will probably respond with an increase of cardiac output.
Yeah, exactly, Thomas. But take care. The most of the studies showed the patient with a special ventilation setting, a tidal volume of 8.5 milliliter per kilogram, a respiratory rate of 15 breaths per minute, and a PEEP between 4 and 5 millimeter mercury.
So if you don't have these settings, the parameter is maybe not as reliable?
Probably not, or I would suggest take another parameter.
Okay, and I'm sure you're going to show us which parameter.
Yeah, exactly. We have spoken about distensibility, but now we have the collapsibility.
Okay, so this is a very interesting parameter, I see.
This is a very interesting parameter and is the most loved in the most studies that have been published in the literature.
Okay, so what is that?
The collapsibility is the property of the vessel to collapse. And it's not very different from the distensibility, and the only difference is the denominator of our formula. Here we can see the formula, and we see that the maximal diameter minus the minimal diameter divided by the maximal diameter, and we'll get the collapsibility index. For values bigger than 36%, we have a sensitivity of 90% and a specificity of 100% that this patient will very well respond to fluids. We can estimate the right atrial pressure too with this formula, and I will show you later some tables. And when we have any changing of diameter, in 90% of the patient, they will be not responsive to fluid therapy.
So this seems to be a parameter which is better than the distensibility index.
It's probably better, and most anesthesiologists use it. To make it easy, we need two diameters, the smallest one and the biggest one. As we can see in our HEMOD, it's very easy to find them and to calculate. Here is the smaller diameter, and this is the inspiration, and here you see the bigger diameter, and this is the expiration. Now you know which values you have to insert in your formulas. And we can see in this table the estimation of right atrial pressure. That could be a very useful tool, but it's only validated in patients that are not mechanically ventilated.
Yes, that's true, and we do use it for transthoracic echocardiography, but even there I would be a little bit cautious because I know of a number of patients who have, for example, a very wide inferior vena cava, which does not collapse or only shows little collapse, and still have normal right atrial pressure. We have a problem that you do not have, right?
Exactly, Thomas. Normally in our patients, it's already inserted a central venous catheter. That means we have online the central venous pressure on our monitors.
Bruno, is there another parameter we can look at fluid responsiveness?
Yes, Thomas. I would like to show you the left ventricular end diastolic area. As you know, we have two different times, is the end diastolic and the end systolic time. And here on the left image, we can calculate very easily the end diastolic area. How we can do it? It's easy. We have to underlie the internal contour of the left ventricle in such a way. Every ultrasound machine will automatically calculate the area of the left ventricle. But, Thomas, for lazy people, if you have already calculated the fractional area changing, then you don't have to make nothing more than read on your screen the values of the end diastolic area.
Okay, so you have the value now, but how will that help you?
Yeah, it's not very difficult. We know that left ventricular end diastolic area less than 10 square centimeter means hypovolemia. At the same time, if we want to index this parameter, we know that values lower than 5.5 square centimeters means hypovolemia too. There is the possibility to measure the end diastolic diameter of the left ventricle. In this case, a diameter less than 25 millimeter means hypovolemia. And the last sign is the kissing of the papillary muscle. As we can see in our transthoracic echo, you see that the papillary muscle during the systolic phase come to each other almost like kissing. That's why the name of this sign.
And what about hypervolemia?
Yeah, Thomas, it is possible with the left ventricular end diastolic area to calculate it, and we know that values bigger than 20 square centimeter indicate an hypervolemia.
But are these area measurements really reliable? Because I have patients who are, for example, hypertensive patients with very small ventricles. Even if they have enough fluids, the ventricle cannot expand. So do you trust these parameters?
Now, Thomas, I don't trust really all these parameters. We have such different situation, and from the literature, the suggestion is that you can consider the parameter when you don't have any wall motion abnormality.
Yeah, and I would also be very cautious in certain disease states. As Bruno mentioned, there are very large variations, and it's not always 100% good sign that you can give them fluids or that you should not give them fluids.
One last parameter that I would like to show you is the left ventricular outflow tract VTI variation with respiration. This is for us, for the anesthesiologist, not a very new parameter. A lot of our mini-invasive monitoring that include pulse pressure variation, stroke volume variation, use the same principle of this parameter. Let's see how it works. We start looking for a deep transgastric view, and then we have to put into the aortic valve a continuous wave Doppler, just like in the left image. And then, if you want to see the respiratory variation, like for the inferior vena cava, you have to reduce another time the horizontal sweep, as you see in the right image on our screen. As we can see in our image, it's very clear to understand where is the inspiratory phase and the expiratory phase. To calculate such a parameter, we have two possibilities. The first one is to make a contour of the tallest and of the smallest curve on our image. And the second one, if you don't have a lot of time or you are a little bit lazy, you have only to mark a point on the tallest and smallest peak velocity. A VTI variation of more than 12% indicates a fluid responsiveness with a sensitivity of 100% and a specificity of 89%. And the same is true for the peak velocity.
Okay, so this is very similar to the parameters you use in anesthesia.
Exactly. Pulse pressure variation, our stroke volume variation are parameters that are very good indicated for min-invasive monitoring, and we can use them if we haven't any transesophageal echocardiography.
Okay. Why does it work actually? What is the physiological principle behind this?
The principle is a very old clinical principle. 20 years ago or 30 years ago, we were used to watch at the monitor and to watch on the arterial curve. And when we see an ondulation or fluctuation in the curve, that means probably the patient is empty and we need to give him some fluids.
Okay, so we're just taking an old parameter and measuring it with a new technology, with echo.
Exactly. Eyeballing is very powerful. If we look at this image, we can see a very circular left ventricle with a normal contraction, and the feeling looks like normal. You can look to the heart frequency too in the most of your patient, but don't forget, in cardiac anesthesia, the most of the patient has a pacemaker or high dosages of catecholamines. That means the real heart frequency is alterated. On this image, we see almost empty left and right ventricle. That would be very easy to say this patient needs fluids, but take care. You cannot perform an eyeballing from only one view. You need more view, because probably in this image we make a mistake to take it and we are in apical position. That means we cannot see very big ventricles.
Right, so I guess if you're too far apical, the ventricle is always smaller, and that can really trick you into believing that the patient is hypovolemic.
Exactly. How I do my eyeballing for the left ventricle and for the right ventricle. I start for the left ventricle in the mid-esophageal 4-chamber view, and then I move my probe to 2-chamber view and then to long axis view. I have 3 images that say me how is the feeling of this heart, but I am not happy because I want to see the transgastric mid-papillary short axis view too. Now I collected all the information about the feeling status of the left ventricle of this patient. For the right ventricle, it's not very different. We need a modified 4-chamber view. That means turn the probe to the right side and put the right ventricle in the middle of our windows. Then you could give a look to the mid-esophageal right ventricle inflow-outflow tract view. And naturally, don't forget, we can look at the right ventricle in transgastric too. And it's very easy because you need a transgastric mid-papillary short axis view that will be modified through turning the probe to the right side, as we have seen in our image.
One question, Bruno. How important is the right and how important is the left? would you look at both?
Naturally, Thomas.
You mean if the right ventricle is underfilled, the left should also be underfilled?
No, it's not always so. You can have some discrepancies. What I have seen very often is that normally you have a very empty left ventricle when you have a problem on the right ventricle. That means the right ventricle after a myocardial infarction will be very big, and the left ventricle will be very empty.
A classic example would be a patient, for example, who has severe pulmonary hypertension and poor right ventricle function. In these patients, you have a very large right ventricle, but there is no blood that passes through the pulmonary circulation to the left. The cardiac output is very low, and then you would have a very small left ventricle. But would you give this patient fluid?
You have to take care giving fluid to this patient. You have to start with inotropy, positive inotropy, because you have to try that the right ventricle take the blood to the left ventricle. And if you have an improving in the contraction, then you can start giving some fluid. But take care, very slowly. I have seen in some patients a very fast increasing of right atrial pressure, and that leads, in the most of cases, to a decompensation of the right ventricle. And I can say you don't need more than 20 minutes for create such a situation.
So the key message here is, yes, use both of them, but you have to know specific situations as the one that Bruno just described, where you have to maybe play around a little bit with fluids versus catecholamines and improving contractility. But coming back to eyeballing, I know you have another trick for us.
Yeah, for sure, Thomas. I would suggest everybody, if you have the possibility, try to compare your images. As you can see in our image, there are on the screen two different views, and one is before the extracorporeal circulation, and the second one is after the extracorporeal circulation. This will be a big help for your eyeballing.
I agree. I mean, this is something I propose also in transthoracic echocardiography, because what we're doing here is something that the radiologists are doing it all along. They compare images before and after. And we need to do that as well in echocardiography. And this is such a beautiful example where you see once the ventricle is small, underfilled, and then we have a normally filled ventricle. You don't need measurements. You see the differences, and they can really give us the proof that the patient now has normal volume. Let's take a more detailed look at what happens in right ventricular volume overload.
Exactly, Thomas. As we can see on the right side on the last image, the right ventricle will be bigger and it will push the septum to the left ventricle, and the left ventricle will show the so-called V shape. But let's see what happens in reality. In this ultrasound image, we see a very big right ventricle, a very empty left ventricle, and the shifting of the septum is very clear to understand with the eyeballing.
Okay, so you can see it on a transthoracic echo and a normal four-chamber view easily.
Yeah.
And this would mean you give the patient
some catecholamines, and I will not give in this moment any fluids.
So to summarize, when do you use what?
I use normally when I have enough time all the images to parameter calculation and to eyeballing. When I haven't a lot of time, I can take only the images for eyeballing.
So as far as I understand you, the more experienced you are, the more you rely on eyeballing.
Yeah, but you have to take care. Even if you have a lot of expertise, take your time to watch the images.